First of all, I'd like to thank you for inviting me here and you all to be here because it's so beautiful, this city, that I don't know what you're doing here. I have to speak about the tremor treatment, the presentation that has been prepared with two of my fellows, Deepa Patalil and Maite Castro-Jimenez. You will see in the presentation there are blue tables, there are some references. These are referring to the chapter that is in the book that you received coming here from Eric Walters and Bowman. I have no disclosure whatever to disclose to you. I have a warning though, because we are from many different countries, different regions, and you have to be warned that approval of the clinical application of the therapeutic approaches presented during this course may vary depending upon the country regulations. Most of the treatments presented have been approved for clinical use, but depending upon the country, those indications may not include tremor. Please refer to your own country regulation, published guidelines, and recommendation, particularly when using treatment of their current indication approval. That being said, I can start. We are still relying on the classification of tremor of 1998. We all know that it will be revised, but we are still relying on this one, and I will go on this kind of classification. When you're dealing with tremor, I think there are three, not sticky one, but three first one that you have to rule out before going into the medication. The first is, of course, physiological tremor. As you know, physiological tremor can be enhanced by many metabolic disorders, anxiety, cold, fatigue, alcohol, and drug withdrawal. And most often, it has not to be treated, but the patient has to be reassured if really, for various reasons, principally the anxiety, as it's my case, you have to take something. You can try to take propranolol, but be careful that the contraindication and the side effects are outbalancing more often the benefit you can have of it. The second tremor you have to rule out is, of course, drug-induced and toxic tremor. Drug-induced tremor, you have a rule of thumb. Usually you have to look at what has been changed in the treatment of your patient the 2 months before when tremor occur, and you will find one of these many medications that can induce tremor. It's very important because the treatment is quite straightforward. You have to stop this medication, reduce it, replace it, instead of trying to adding another one to treat this tremor. Sometimes you can't reduce or stop a medication, and in this case, if you are dealing with a Parkinsonian type of tremor, anticholinergic drug can be used, especially for Parkinsonian tremor induced by neuroleptics. And when you are dealing with a postural tremor, the medication used usually for essential tremor, beta blockers, and primidone can be used. So I have small studies on specific drug-induced tremor, like valproate, that can be treated and respond to acetazolamide, propranolol, lithium, propranolol, and primidone, or tardive tremor, when you can use also atypical neuroleptic like clozapine or tetrabenazine. The third one is a psychogenic tremor. This can be tricky. Psychogenic tremor is a positive diagnosis. You know the clinical clue: sudden onset, remissions, fluctuations, unusual combination of tremor types, decrease of the tremor during distraction, variation of amplitude, rhythm, direction of the tremor with contralateral activation, entrainment, or co-contraction. It needs to be diagnosed first because it needs to be treated differently by a multidisciplinary approach. I will allude to a recent paper about retrainment, but especially this kind of tremor, if missed, can lead to polypharmacology, undue surgical therapy, and undue multiple investigation. So it's worth having that in the head before going first. I was alluding to this very recent paper from the group of Tony Lang that tried to help these patients with psychogenic tremor by retrainment with external clues, and they managed to have a quarter of these patients almost cured of the tremor by these kind of physical therapy. Now, having said that, we are dealing with what Helen calls sticky 3. Essential tremor is a challenge. You know that the prevalence is around 1% of the population, depending on the surveys. Increased to 4 to 5% above the age of 60. In this survey, functional impairment is told by the patient in 60% of the case, and around half of them report impact on their career, although only 5% report to be treated. So this population is impaired and probably not adequately treated. What do we have for treating them? Well, there have been many evidence-based guidelines. The Italian one, I think, is from last year, but mainly nothing changed. Between 2005 and 2011, there were no new medications for essential tremor, but a lot of medications that were reclassified as inactive in tremor. We're still currently with 2 major medications, maybe 3, propranolol, primidone, and the association of both that is more effective than any of them taken alone, and more recently topiramate that have been included in this first line in some of the guidelines, depending upon the countries. The second line is atenolol, sotalol, gabapentin as monotherapy and alprazolam. There is a third line with a few small studies for clonazepam, botulinum toxin, clozapine, nadolol, and nimodipine. The white box is all the medications that are of unknown effectiveness, and the even growing black box is all the medications that have been proven not efficient in essential tremor. The 2 major medications have very common side effects, and these side effects leads to discontinuation of the medication in a quarter of the patients for the beta blockers, in half of them for the primidone. Taken together, around 43%, around 50% of ET patients may benefit from these medications. So you are left with 50% of your patients not adequately treated with the current available medication. Good rule is to start low, go slow, because you don't have many trials. You have to explain to your patient what will happen. Actually, they will have to trade their tremor annoyance against some side effects annoyance. And it's better that they know it before they experience it. Otherwise, they just drop the box and you don't succeed to treat them. Although it has not been proven by statistics, introducing lowest dosage to start with and then increasing over a long time seems to me a better way to go than giving from the upfront quite high dosages. You have to increase up to the maximum dosage or effectiveness of this medication. If the tremor resists and is still impairing daily life, then you have to associate a second drug before reducing the first drug, because both drugs, propranolol and mesalazine, are more effective than any of them taken alone. And so you will be able to improve around 50% of these patients. For Parkinsonian tremor, there has been few also guidelines, and these are the European EFNS MDS European section review, 2 years old now. 10 pages. These 10 pages are about the treatment of Parkinson's disease. You will find, I think, one paragraph and one part of a table about the treatment of tremor. And in this table, you will find that anticholinergic can be proposed to this patient. I just wanted to warn you about that. Actually, there is any study proving that tremor in Parkinson's disease will respond better than the other bradykinesia and akinesia and rigidity to anticholinergic, and this is the very first paper about anticholinergics in Parkinson's disease. And when compared to either agonist or levodopa by clinical use or by electrophysiological use, there is strictly no significant difference, no benefit to give anticholinergics proven. On the other hand, there have been clues warning us that patients that have been exposed to anticholinergics are more prone to develop dementia during the course of the disease, either retrospectively or prospectively, in this paper on GNNP in 2010. In other words, you have no good reason to give anticholinergic. They don't have better efficacy on tremor, but you may harm your patient by giving them. And I think they should be, if they are still used, they should be used with a lot of cautions. It has been alluded to in a question just before, and it will be presented in this meeting by the group of Jankovic, that there are some overlap between ET and PD. I don't want to go into detail. There is a very good session about that, and I think it's a nonsense for me to speak about more about that. But for treatment, you have to realize that that happened. And we had this patient reported in GNNP a few years ago now. This patient was addressed because of unresponsive tremor. As you can see, on the right side, between A, B, and D, the tremor is improved by antiparkinsonian medication, either levodopa test or apomorphine test. But the left side tremor was not improved at all, not touched at all. It's only when we associated the antiparkinsonian medication to primidone that the patient was helped and improved both sides. So this happened, and you have to keep that in mind. So in summary, for PD tremor, you have to treat PD based mainly on bradykinesia and rigidity, which are the impairing signs and symptoms, and follow your PD guidelines of your country. You may increase dopaminergic medication if quality of life is significantly affected by the tremor, and sometimes you may need pretty high dosage to be efficient on the tremor, but you may see dyskinesia appearing. If action tremor, higher frequency usually, it has been alluded to by Ilan just previously, if this tremor predominates, you may also add essential tremor medication like propranolol or primidone. If significant tremor resists, anticholinergic in very young patients or clozapine may be tried, but I think it's better to go to DBS, because DBS is, tremor is the only sign of Parkinson's disease that responds better to DBS than to medication. I will come back to that later on. Dystonic tremor, the third of these sticky three, has been around since a long time, but has had a revival these 3 last years with a lot of publication on them. It's something that we all knew, but we did not really pay too much attention before. And for treatment, it has been the case as there are strictly no study dealing with the dystonic tremor. There has been a nice review by the group of Tony Lang last year, and the bottom line of this paper that if you're interested you should read is that there is no study speaking about the treatment of dystonic tremor, but the dystonic tremor is embedded into essential tremor or into dystonia. They end up with a proposal that is to treat primary writing tremor, tremor of head, jaw, and vocal cord by botulinum toxin, arm tremor, and with addition of the other one with anticholinergic, tetrabenazine or clonazepam, and association of these two approaches when there is predominantly a focal tremor or a more generalized tremor. If it resists, then you have to think about DBS. If the dystonic part, the posture is predominating, you may hit for the GPI. If the oscillatory part is more prominent and the more impairing the patient, you may hit for the VIM, and sometimes you may have to associate both these DBS to be efficient. For the other type of tremor, I won't go into details. They are in the book. There are few studies, case reports, but I did put in bold here that in all these situations, DBS is also coming in front line these years with VIM, subthalamic area, thalamus, GPI, depending upon the very little small series. I think it's still a domain of research for now, but these are possibilities to treatment for these patients. Neurosurgery has been present since years, actually in the 60s already. And for tremor, it has been very efficient, but unfortunately, with the thalamotomies, as you all know, as soon as you do bilateral lesions, you have major side effects like dysarthria, gait disturbances, and cognitive difficulties. Thanks to Alim Benabid and Pierre Pollack, since 1991, we have this possibility to use DBS in the VIM with a marvelous efficacy. Even in the first paper, tremor of Parkinson and essential tremor were mixed together. And most of the paper you will see will have deal about tremor, but we'll have a mixed population of ET, Parkinson's disease, and sometimes also secondary tremor. Whatever, if you look at these papers now, we are almost 20 years down the discovery of this treatment, and there have been quite a lot of long-term studies showing that the efficacy of DBS in essential tremor, VIM, and in the caudal zona incerta, which is just the subthalamic area, or for Parkinson's disease, subthalamic nucleus and GPI. All these targets are very effective, with effectiveness about 70 and 80% of the reduction of tremor, which means that if you're left with 50% of your patient because of the medication, you can treat 80% of them. Total is 90% that can be treated, potentially. I remind you that only 5% are treated. The efficacy of the DBS is maintained over time, but sometimes there is some reduction, and it has been already mentioned just before that can be due to either the progression of the disease or displacement of the electrode or the habituation of the circuit that we really do not understand. That can be overcome in this last possibility by stopping the stimulation during the night and doing this kind of cycling. Sometimes you may restore the efficacy of the DBS. DBS has also been shown as effective in secondary tremor, like here in multiple sclerosis. with similar efficacy. But for all these studies, there are 4 or 5 papers, the efficacy is maintained for, has been proven for 6 months to 1 year. There is only one very long-term study reporting the effectiveness of DBS in MS, and the bottom line is that although it remained to be efficient, the progression of the disease make that the improvement led by the DBS is lost after 3 to 6 months, although exceptions exist with improvement lasting longer for up to 5 years. DBS has complications, and that's why we don't use them firsthand. Surgery-related, we have around 2% of complications that can be deaths, hemorrhage, or permanent neurological sequelae. The hardware that you have to stay with, the wiring, the batteries, leads to up to 10% of complication over the time. With infection, lead replacement, extension replacement, and battery, of course, have been to be replaced almost every 4 years. And there are some side effects that are transient. Of course, when you tune the DBS, you may almost always have some side effects: paresthesia, eyelid opening apraxia, amygdalism, and so on. But these can be tuned, although the first ones are mostly definitive. So there are, again, try to go back to closed surgery and no batteries. And there are 2 ways these days that have been published since around 7 years. The first is a gamma knife thalamotomy. Gamma knife thalamotomy allowed to make lesions that are radiotherapeutically induced, and these very restricted lesions are actually doing the same than thalamotomy, open field thalamotomy before. There have been 6 studies, some retrospective, some prospective. The last one I encourage you to read is one which is single-blinded by Paul Crack, about 50 patients with Parkinson tremor and essential tremor. And all these studies, and especially this last one, report an effectiveness of this treatment for unilateral tremor in around 50% of the patient, which is not as good as DBS, but not bad, considering that you reduce the surgery-related and device-related risk to almost 0. There are some permanent side effects in these studies, particularly if the dose that has been used is above 130 gray. So it's in the Young paper and in Korshabashi paper. When you stay with 130 gray, it seems to be more safe. The other approach is MRI-guided focused high-energy ultrasound thalamotomy. Here we have also 4 very recent, very small series paper about mainly their essential tremor, one about Parkinson tremor by Schlesinger this year. You see that the patients are very small numbers, but here also they find a quite good efficiency with reduction of the tremor between 50 and 80%. There are some non-responder, though. Around 30% of the patients will not respond, probably because of the skull. I did not go into the detail here, but it's also a promising technique. If you want to compare these different techniques, the currently available and effective, and I think accepted everywhere, is DBS. It has long-term results. The targeting is quite robust with MRI, electrophysiology, clinical during targeting during the operation, although it's invasive and there is material in the patient. It can be performed bilaterally. Radiofrequency is still available when in some places. We don't use it almost not anymore in my country. We have long-term targeting is S for DBS. It's also invasive, but it's not reversible, and usually the past have found, has showed to us that there are many side effects, so that's why it's almost abandoned. The two other one, we don't have long-term, but they seems to be quite effective. The targeting is less robust. You don't have electrophysiology because you don't go into it. With high energy ultrasound, you can have some clinical clue during the procedure for the targeting. For the gamma knife, you don't have any clinical clue. The effectiveness of the gamma knife is building up over months after the procedure. It takes around 6 months to 1 month to establish the effectiveness. We don't have, it's not invasive, these two methods, and that's their main advantage. Just want to finish by reminding your paper, Ellen, a survey of medication usage among essential tremor patients in your area. The duration of tremor before a neurologist is 10 years. Between a neurologist and movement disorder specialist is around 9 other years. That's 19. There have been, in average, more than four medication trialed before in 30% of the patient. We have 3 medications that have been proven efficacious. The medication before surgery are around 6 plus or minus 3. We still have only 3 medications that have been proven efficient. So why do we delay so much that duration of tremor before surgery is around 27 years? In Parkinson's disease is less than 10. I think we have to improve things there. For concluding, I would say that tremor treatment starts when treating the cause, medication, physiologic, psychogenic, other movement disorders. The medical treatment of essential tremor relies only on 2, maybe 3 first-line drugs and 5 second-line drugs, improve compliance of your patient, and you may reach 50% of efficacy. Treatment of PD tremor follows the general rules of PD treatment as for the other major signs. If predominates on action, consider to add also essential tremor treatment. When severe tremor resists medication, consider neurosurgery. You may help the 60 to 80% left of your patient, of your 50% of patients that you are not able to treat with the medication. In secondary tremor, for example, MS, you have to balance the risk with the progression of the disease as a benefit you may have with wane because of other impairments. If contraindication to surgery, you have to enter protocol for new treatment. For example, the gamma knife, the focus high energy ultrasound, and you may reach 90% of efficacy of treating this tremor. You have to tailor your treatment with the patient and participant to clinical research. I thank you for your attention.